Uh, we are just trying to cover some of the topics related to regional anesthesia choices in lower limb surgery and surgeries below the umbilicus. We just discussed some of the basic concepts about regional anesthesia. And my focus, because landmarks is written everywhere, and that's actually only cramming. So that's not at all a problem. The concept of where to use the specific blocks, what are the shortcomings, what are the pitfalls, and how to use them, this is more important, because regional anesthesia is something, actually a thing which is practically being done even in the exam. They will not ask you to perform a block. They will just ask you to explain why you are giving that block, and what will be the shortcomings and what are the problems related to it. Okay. The people who have listened the previous discussion, if any questions before some more people join, anyone wants to ask any question? Okay, before I will start, I will ask a question to anyone. Anyone knows about what is enhanced recovery after surgery protocol? ERAS. Anyone know what is ERAS protocol? Actually, ERAS protocol is it's called as enhanced recovery after surgery. Enhanced recovery after surgery. And the concept of this protocol is to reduce the hospital stay and decrease morbidity and mortality. And there is a perioperative plan for that. Okay. So there will be a mutual discussion about an individualized plan with reference to any condition which is there, and make some general protocols. That some of the things which they do preoperatively is that they prepare the patients well, the preoperative evaluation, and chalking out any risk factors, correctable things, they correct those things, and then making a surgical plan and an anesthetic plan, mutually try to have minimal stress response, minimal invasive surgery. So this is another aspect. And then try to reduce aggressive preoperative preparation, like keeping patient to MTO for a long time. Okay. And plan intraoperatively give the medications which are relatively just a second, because actually this is related to this surgery, so I thought to just revise it before. Where is that article? Just a second, please. Actually, I have missed that article. Sorry for the interruption. I just wanted to show you. Okay. So actually, this is the basic concept of IRAS that optimize preoperative preparation for surgery, avoid heterogenic problems such as postoperative ileus, minimize the stress response to surgery, speed recovery, and return to normal function. Okay, it does not necessarily means that you will discharge the patient on the same day. It is just to reducing the hospital stay. Okay, because whenever there will be more hospital stay, more chances of infection, more chances of DVT, more chances of pulmonary embolism. Okay, and of course, more financial burden. Okay, so this is the concept to avoid the stress response, because in the stress, all the dangerous hormones will be increased. There will be like sympathetic stimulation. Okay, there will be increase in ACTH, cortisol, which are all diabetogenic. Okay, insulin will be reduced, and insulin resistance will be there, and ADH, growth hormone, like all of these things are leading to, because this is to counteract the stress. Okay, but if you reduce the stress, like you see in this chart, you can see ACTH, cortisol, growth hormone, insulin like growth factor 1, ADH, okay, glucagon, and reduce and improperly lower insulin, and there will be negative nitrogen balance, like there will be more catabolism, glycogenolysis. Okay, so this is what is the stress, and then when you reduce the stress, you reduce the myocardial oxygen demand. Okay, and when you are decreasing the response, you are avoiding a number of problems which you can, because the topic for today is of our topic is knee surgery, and actually knee surgery, they are using this protocol. Okay, so some of the important thing related to analgesia will be to, because if they want to mobilize the patient early, they don't want any block which is causing motor blockade and the patient is unable to walk. Otherwise, epidural will be giving a very superior analgesia. If you are giving femoral nerve block and sciatic nerve block, patient will be totally pain free. But a problem will be that patient will not be able to ambulate, and there will be problem related to postoperative course with reference to this one physiotherapy. Okay, so they need to have something in which they speed up the process, and they manage the patient in a way that they reduce the this stress pathway. Okay, so that's why I just wanted to tell you that what are the things which can enhance the recovery. So if you want to understand the knee, the concept of this motor sparing nerve blocks for knee and the whole concept, you should be knowing what is IRAS. So that's why I started with IRAS. So IRAS is the thing which they are using now gradually. They started with this gastrointestinal colorectal surgeries. Now they are trying to do it in almost every surgery, orthopedic surgery, cesarean section. As you see, there are articles now for pediatrics as well. They are doing it for almost all surgeries. Okay, so this is the concept. They will try to admit the patient on the same day, avoid bowel preparations, prolonged fasting, and there is a concept of this carbohydrate drink. Okay, this will also result in reducing the stress response. They gave it 2 hours before clear carbohydrate fluid, like sugar, like dextrose. Okay, so this will be helping, and avoidance of sedative pre-medications. Okay. So these are, and of course, optimizing the patient's condition preoperatively. Okay. So intraoperatively, as I told, they will try to avoid drains. They will try to avoid putting Foley's. Okay. They will try to use medications which have less metabolism. Okay. They will be having a very good pain relief, multimodal analgesia, concept of preemptive analgesia. Okay. So that is the concept. Okay, thromboprophylaxis, risk stratification of PONV, because PONV, you know, will be surprised. The PONV is one of the thing which will lead to hospitals, prolonged hospital stay. So that's why they are focusing on it, that thing. Okay. So I just gave you an overview about it, and that there will be a mama which will be smiling after surgery. Like they will try to break the NPO at the earliest possible time. They will try to avoid morphines, avoid electrolyte imbalance, avoid hypovolemia, because that will be leading to postoperative ileus. Okay, if drains will be there, it will be creating problem. There will be more chances of infection, and there will be more chances of patient not able to mobilize. Okay, so I hope you understand. Any confusion in it? Okay, so that's what I just wanted to show you. That's how this is a chart you will be understanding. Okay, so there will be primary care preparation. You can just have a look at it. No NG tube, no regional with the sedation, use of regional with sedation, epidural management. Okay, and they try to reduce the concentration so that there is less motor involvement. Okay, physiotherapy and but do you think, is there any problem with the fluid therapy if you give less fluid or more fluid? There is silence today. Nobody is speaking out. Yes, Zunaira? Shmail? Anyone?
With the more fluid, it can lead to compartment syndrome, but not in the knee surgery. I don't believe it will be in the knee surgery.
Compartment
But
syndrome? How it is?
no, I was thinking in another way. But it's a knee surgery, so there is no connection with that.
No, just tell me one thing. What is the role of fluid management in, for example, if I just give you an example, this intestinal anastomosis? Is there any relationship with the fluids with this thing? Anyone, please?
Sir, for these patients, we have to, no, we don't do, but the surgeons do, like the pre-op. They are given...
Listen, Zunaira, your words are wrong. This is not surgeon's responsibility. I will just tell you something. Everything which is going on is responsibility of anesthetist. Okay, even we have to clean the wrong things done by the surgeon. So never say like that this is responsibility of surgeon. No, it's your responsibility. But I am asking some other question. Intestinal anastomosis, of course, it will be intraoperatively. Is there any relationship of giving fluid therapy with this anastomosis? Anyone, please? Yes, Dr. Abu Bakr.
Yes, sir. In anastomosis, giving more fluid, it makes them.
Yes, you are telling the right answer, but unfortunately,
chances of failure of anastomosis.
Yes, please, Abu Bakr, just repeat it because your voice was distorted. So I don't think so people listen. Please say it again. You have told the right thing.
Actually, yes, having problem with my internet today. I was saying that the more fluid will lead to the failure of anastomosis because it will make the union edematous.
Edematous, okay. So now you understand, but at the same time, this is one story, but the other part of this story is that before they reach up till the level of anastomosis, you try to correct the dehydration, okay? Especially if there is some free fluid in the abdomen. If you don't anticipate and the abdomen is open, patient can suddenly go in hypotension, okay? So this is another aspect. So that's why the concept of gold directed fluid therapy. This is the concept, the key thing. Okay, but remember one thing: at this point, when they are doing the anastomosis, try not to give too much fluid. That's why you should be looking at the gut, how it is. If you are seeing that it is looking too much engorged, it is better for you not to give fluid at that time. Okay, thank you, Abu Bakr. So this is the concept which and for example, at the similar time, if you don't give fluid and patient is dehydrated, so dehydration is a big cause of PUNV. There will be electrolyte imbalance. Okay, so this will be resulting in ileus. So that is why this is very important. Okay. Okay, so you have to give very good analgesia. Everyone is clear about preemptive analgesia? I use this word. Anyone doesn't know about it, just tell me so that I speak out again. What is preemptive analgesia? Everyone know about it? Jamil, you are here today. You can explain something. Okay, preemptive analgesia is just giving some analgesic medications before the incision, before the actual stress comes. So that's for that purpose they are using paracetamol, NSAID, and gabapentin. Gabapentin is used for opioid sparing, and it is a way of getting preemptive analgesia. Okay, so now we will go to the main topic which I wanted to discuss. Okay, so actually the concept of there was something which I couldn't actually recall. Yes, Zunera?
Sir, as you described about the preemptive analgesia, like you are talking about paracetamol and NSAIDs.
Yes.
Is it normal routine giving those, or it's been done also with the fentanyl?
Fentanyl, you know, just tell me one thing. How much is the duration of action of fentanyl?
Sir, it's peak around 15 minutes to 20. I don't remember it well.
So
I'm sorry.
it is not more than 30 minutes. Okay. It will not remain for more than 30 minutes. So this is so what will be the advantage? Okay, when you are giving paracetamol and NSAIDs, it has relatively longer duration. Okay, fentanyl is being given for preventive analgesia. What is preventive analgesia?
Sir, preventive or preemptive?
Preventive. I'm sorry for my writing.
Preventive is for.
I'm not very good in writing with the stylet. Preventive and preemptive.
The preventive will be the before the incision, no?
Anyone, please?
Preemptive seems like it's sufficient analgesia, and preventive seems like to lower the stress response.
Yes, you are right, but actually preempt means how? What is the literal meaning of preempt? Preempt is that you are anticipating something, or you are trying to react before it happens. Okay, so like you can say that it is something has not happened, you are trying to prepare some response to it. So that is the concept of preempt, that you are preempting that there will be an incision. Okay, and preventive is that when, for example, you know that fentanyl effect is up to 20 to 30 minutes. So you have to give it before the effects finish. This is one thing. And another thing is that if there is any critical step, like for example, you started this one cabbage and the time of sternotomy. Okay, this is a extremely painful procedure. You are doing the neurosurgery and they have to put the pin. This is a very painful procedure. Similarly, you will find a number of things. So at that specific time, before that, you are giving extra medication or respond. This is preventive. Preemptive analgesia is before the onset of NCN, because the onset of surgery. Okay, so actually these patients who are coming for knee replacement usually have osteoarthritis. Okay, so osteoarthritis, what things will you be thinking? That there is a vicious cycle, they are not able to move, so they are morbidly obese. Okay, then they may be taking NSAIDs. So NSAIDs related bleeding, peptic ulcer disease, renal failure. Okay, then the patients can be on steroids. So all the concerns related to steroid, like salt and water repair. Please mute the mic. Okay, steroid, osteoporosis, salt and water retention. Okay, and you are taking exogenous, so the hypophyseal pituitary axis is suppressed. Okay, so you will be expecting, or there may be some other disease like rheumatoid arthritis, like any septic arthritis, like any seronegative spondyloarthropathies. Okay, like you should be thinking that this patient is coming for knee replacement, but majority patients will be old age, so there will be concern related to old age. So all the altered physiological, pharmacological, and anatomical consideration related to old age. So you should be keeping all these things in your mind. If the patient is having rheumatoid arthritis, you have to anticipate, or any other specific cause. So when you are dealing with these patients, you should be like mentally prepared for these things. If patient is on steroids, you have to give the steroid stress dose replacement. If the patient is an NSAID already and the renal functions are, you have to act like you should be anticipating accordingly. Okay, so this is one thing, and actually I wanted to read about it. Does anyone knows about this bisphosphonates? Actually, it is for osteoporosis. Okay, but I couldn't read about it. You can just have a look what are these bisphosphonates, because these osteoporotic patients, they are sometimes on these medications. Okay, so now when you are making the analgesia or anesthesia plan, what will be your considerations? Like what are the, for example, if I ask you what are the choices, so one will be GA, okay, or GA with the with epidural, GA with the any nerve block. Okay, so or for example, you can get, if the surgeons are quick, you can have spinal, and then you can put a adductor canal block, which will be giving motor sparing. Okay, but it will not have all coverage of the knee joint. We will just shortly look at it. What are the nerves for knee and what nerves you need to block. Okay, or you can do it in combined spinal epidural. Okay, with the post-operatively, you will try to have as minimum like 0.1 or even 0.0625% of bupivacaine. Okay, okay, so What are other options? Like what other options for analgesia you can think about? The same like just which I tell again and again, paracetamol, combination of paracetamol and NSAIDs. If there is no contraindication, then short acting opioids, like if you are giving of course if you are giving GA, remifentanil infusion, okay, fentanyl, or then morphine, okay. And then as I tell before, lidocaine infusion, you can give dexmedetomidine. This is the multimodal analgesia plan which you are using for any patient, okay. So you can have all these intraoperatively and postoperatively. You can just put a adductor canal block, plus you can put on PCA morphine to to top off the area which is not the pain, additional pain relief, which you cannot cover with the adductor canal block, plus of course paracetamol, okay. And you can have some opioids, weak opioids, like not causing significant respiratory depression like tramadol, okay. So this may be one of the plan. So they just have recently introduced some of the block, which I have never done it by myself, but I just read about it, and maybe it is giving some superiority. So first of all, this may be known to you, that you should be knowing what are the nerve supply of knee, okay. So they are getting component from femoral nerve, obturator nerve, sciatic nerve, okay. So here you can see that this nerve to vastus laterale or vastus intermedius and vastus medialis, you can just see the abbreviations, okay. And vastus intermedius, what is this? SMGN, superior medial genicular nerve, okay. Superior medial genicular nerve and inferior lateral genicular nerve. In these yellow color are branches of common peroneal sciatic, okay. And this one is IMGN is a branch of tibial nerve. So now you see that the major portion is from knee of the from the femoral nerve, okay, but some portion of common peroneal nerve is also there. And if you see, the posterior portion is more through the this one sciatic nerve branches, okay. So that will be not covered. Even if you give adductor canal block, you will block some of the nerve supply here, but you will not be able to get a perfect analgesia, okay. So that's what they are telling. The supralateral anterior aspect of knee capsule is supplied by nerves to the vastus lateralis and intermedius, both are branches of femoral nerve, by the superior lateral genicular nerve and by the common peroneal nerve itself, okay. And supramedial anterior aspect of knee is innervated by the nerve to vastus medialis, vastus intermedius, at the same chart which we have seen. Actually, no advantage of just repeating it. So these are the options. A femoral nerve, femoral nerve block, if you are giving, you will get a very good analgesia, but what will be the problem? That there will be motor loss, there will be quadriceps weakness, so patient will not be able to mobilize, even if you are giving 0.1%. You see, quadriceps weakness and reduce mobility, okay. So adductor canal block was proposed to add alternative to femoral nerve block to decrease the risk of quadriceps weakness, but still providing good analgesia after knee operation, okay. It was described with subsartorial canal. Yesterday I showed you the landmarks for that one as well, okay. So it was described using ultrasound at the midpoint between the anterior superior iliac spine, and the base of the patella. Like they will count from up to down, midpoint, and then track medially, because it's difficult to explain the technique. But for ultrasound, I will give you a tip that if you understand the basics of ultrasound and you learn how to manipulate the needle, you can give any block. And for that, I will tell you that you take, if you don't have even the mannequin or anything like that, because in good like Western hospitals, maybe there are some mannequins as well to practice this thing. But the easiest way you can learn is that you just take this one normal saline, and you put some jelly, and you put the ultrasound probe, and you try to manipulate needle around it. You will learn how to place the needle under the ultrasound probe. So once you understand, you are able to see how you manipulate the needle and how you get the vision. The rest of knowledge blocks is very easy, because usually, as I told you, that everywhere, whenever you are placing almost 90%, 99% of peripheral nerve blocks, you will find some of the vessel around it. So you will be finding the vessel, you will put the Doppler, you will confirm the artery, and there will be something medial, lateral, the superior, posterior, you will find the nerves. So the first thing to learn is how to visualize. And another advice I will tell you, that if you have ultrasound in your setup and you don't know, like you are not in a very good practice, just try to see the videos and just try to, if possible, just try to put on, like for example, if there is surgery going on in the lower limb, you can put the probe in the neck to visualize some of the vessels of the upper limb. Of course, there will be ethical issues, but if it is possible, this will be a good way to learn. Okay, so this I just wanted to share with you. And so they have just told about some of the techniques of these block. Okay, and later on they recently, but the problem was that still there was not adequate pain relief. Okay, so then recently they have introduced a block which is called as IPACK block. Okay, and it is mnemonic for interspace between popliteal artery and capsule for knee. Interspace between popliteal artery and capsule for knee. Okay, and you will be, it's something good for Asians, that this block was described by one of the Indian. It's just like, do you know that tab block, transversus abdominal plane block, was identified also by one of the Asian, Dr. Rafi. Okay, many decades ago, tab block. Okay, so similarly, so they are what is the concept that they are trying to put. There are so many minor branches which are coming, and they put the local anesthetic volume in the area where nerves are reaching the block. Okay, so that's a consist of infiltration of local anesthesia between the popliteal artery and the posterior capsule of the knee. Okay, the goal of IPACK block is to anesthetize the articular branches innervating the posterior knee joint while avoiding the blockade of tibial nerve and common peroneal nerve. So actually, this is a relatively newer block. So still they have to evolve what is the absolutely correct technique. And the problem is that local anesthetic can migrate, and in the nearby area, not very far away, there is a sciatic nerve. The branch sciatic nerve is branching into common peroneal and tibial nerve. So their aim is not to block them, because if they block them, then again there will be weak this motor weakness. Okay, so that is the thing which, if you understand this concept, that what is IPACK block, it is where it is placed, what is the concept, and it is to provide the sensory block to knee. Okay. So they have just placed about the technique. Okay, this is pulmonary artery, this is femur, and then they go a little. I was just watching the videos about it. You can watch about it, and then they found the hump and they will introduce here at this place. Okay. Yeah, this is, they have marked this area. They have to, this is what approach, sorry, just for ultrasound. What is this? What you say? Short axis, long axis, in plane, out of plane. Anyone, please, who does it? Don't tell. Who doesn't do it? That person tell.
Sir, it's in plane
Yes.
and it's
Yes, you are right.
the axis a short axis, I believe.
Yes.
Yeah.
Yes, it is short axis. Okay. So it is in plane short axis. And actually, if you put the needle so far away, actually, you need to travel a lot. So that's why this is basically they are using curvilinear probe. So that's why they have placed it a little far away. Okay. Otherwise, if you are using the straight probe, most probably you need to place it a little nearer and should be going under the ultrasound probe. Otherwise, you will not be able to see it. Okay. And this is another concept that you try to visualize the figure that, for example, this is your area. The artery is your area. Yes, Talha, please. Yes,
Sir, I sir, literally just disagree with this point, sir. The
okay.
probe which we will use in this practice is linear probe, and
Okay.
the space is this far away, and we utilize the needle very goodly.
No, but how will you visualize it? It is curvilinear probe, no? This seems to be curvilinear. This is curvilinear. This is not straight. This is curvilinear. You see, you can see.
Sir, I'm not talking about this probe.
I understand your point. I understand your genuine point that if you are saying that if you are you have to reach you have to decide according to the place you are targeting. Am I right? That's what you wanted to say?
Yes, sir. Yes, sir.
Yes. But the basic thing, you remember one thing, that majority of the blocks we are giving it with curvilinear or straight probe.
It's a straight probe.
Straight probe. So a straight probe,
Yes.
actually, because the problem is that straight probe does not have too much it is not giving you a very deep. Okay. So anyways, you have to be slightly nearer to it. So your point is absolutely perfect. Okay. So, but remember one thing, you have to, because there is no single word answer for this question. Okay. Your point,
yes.
though, is very clear. Okay. Thanks. Yes, Dr. Sadia.
Sir, straight means linear probe.
Yes, straight. I'm sorry, linear probe. I used the wrong word. Linear probe. Okay.
Okay, sir. Thank you, sir.
Okay, so actually, even they are also injecting morphine in the joint. I have seen some people doing it, morphine, and they also add tranexamic acid. Tranexamic acid, morphine, local anesthetic. They have tried a number of things. Okay. So genicular branches are also, genicular nerve block is also being used. A distal blockade of genicular branches has also been described using ultrasound. Okay. So actually, because the ultrasound era is now, this is now ultrasound era, and you should be knowing if, like, a point of care ultrasound will be now almost mandatory. Okay. So the shortcoming of this block will be that if you are happening, yes, yes, Zunera.
Sir, how much morphine can we use for, like, 100 mics? I know it's for the epidural, no? For the spinal.
Yes, no, but it is not for here. You will have slightly higher dose. maybe 2 to 3 milligram, even 5 milligram. They will inject in, they will put it in this combination, which
And
which they are giving in the peripheral nerve block.
and the tranexamic acid? How much?
Tranexamic acid, actually, I don't remember the exactly doses, but usually the same dose. You see usually how much dose we are giving IV. We are giving around 10 to 20 milligram per kg. Okay. So similarly, it will be like 1 gram we give, that is around 15 milligram per kg for an adult. So almost same you can give it here. Okay. In the exam for these are actually practical aspects. So practically maybe you need to know, but I guarantee you that such questions, such blocks will not be asked specifically in the exam, and they will not fail you on these these blocks on these adjuncts doses, because there is no recommendation for them. A number of things there are no specific trials for those things, but still people are using it. Okay. So that's what I wanted to discuss today. Any questions, please? So plus just do have a look on this article, because this knowledge you will not get it from any book, I can guarantee you. Okay, this is the you see this article is very old, 2007, but you will see that all the things are perfect. Yes, I forgot to mention, because I sent a message about the possible one thing will be tourniquet. Okay, so in this bleeding, tourniquet, use of this bone cement, use of tranexamic acid, and if you are not able to mobilize the patient, chances of this venous thromboembolism. Okay. Actually, knee surgeries are also the arthroscopic surgery. So for arthroscopic surgery, the more important thing is that from where they are inserting the port. Okay. So different techniques they have chalked out. This article, you see, that's why you will find in one place everything which I was trying to find, because I have not read these articles, all of them, because now alhamdulillah a number of things I know, but these articles, I just imagine that if when I was a student I used to have these sources, I would be a much better student at my postgraduate exam. Okay, so that's what I am preaching. I'm just trying to pull you out of the books, and you will see that okay. Actually, you know, in some places you will find preemptive analgesia and preventive analgesia similar, like they have written like here. You see, just a second, just have a look. They have written preventive analgesia as what I was telling you as preemptive analgesia. Preventive analgesia involves administration of analgesics prior to noxious stimulus, with the aim of preventing central pain sensitization by inflammatory cytokines. In some books, you will find this as preemptive analgesia. So actually, the concept is that preempting, and you are preempting before. So more appropriate word is preemptive analgesia. But preventive analgesia can also be used. And preventive analgesia is before any additional requirement you are giving it. This is also preventive analgesia. Okay. I think it is enough. Another thing, how much tourniquet pressure you need to give. You see, you find the answer here. I did not read it, by the way. I'm telling you the practical, Zunera, the question which you were asking, 10 to 15 milligram per kg. You see, tranexamic acid, it's written here, 10 to 15 milligram per kg. And what about the tourniquet pressure? How much tourniquet pressure you should be putting?
25 mm of Hg.
No. 25, no. Anyone, please?
Or should be more than the systolic?
Depends upon the limb and the systolic pressure. If you were talking about the lower limb, there are two school of thoughts. Some are telling that 150 millimeter of mercury above the systolic pressure for 60 to 90 minutes. And there is one study in US about nursing study
occlusion.
that
Limb
yes,
occlusion.
they told that now for individual, every patient, first you measure the blood pressure of that patient, and then for the upper limbs is above 100 millimeter mercury above the systolic pressure.
Jamil, just explain a
Sorry.
little bit that they are taking the blood pressure with the Doppler. Sorry, they are taking the pulsation with the Doppler to get the exact pressures.
Yes, sir. In the lower limb, then they increase or they fix the blood pressure above the systolic. For lower limbs, it's 150
100 to 150.
and
For
100,
upper limb
150.
or if they are not doing it, usually it is 200 for upper limb and 300 for lower limb. Am I right? In adults.
Yes,
Like this, Jamil?
different to different, from 200 to 250 and
Yes.
250 to 300 in lower limbs.
Okay. So because when you are inflating the tourniquet or deflating the tourniquet, this is also a serious problem, and also bone cement syndrome. Any orthopedic surgery, think about bleeding, think about tourniquet, think about bone cement syndrome, think about embolism. So 3-4 things you should never forget it all, because it will be there. Okay. So thanks a lot for your presence. Thanks, Jamil. And I hope this topic is clear to you. We will start some other topic, inshallah. Okay.